So thank you very much for inviting me to speak, and thank you to Malcolm particularly who asked me to come and speak today. So as introduced, I am a clinical oncology consultant from University College London Hospital. Tried not to put an acronym straight on the thing, so we are otherwise known as UCLH. And my major interest is actually the other end of the spectrum, is paediatric radiation oncology, and I'm going to explain to you why that interest has led to my interest in proton beam radiotherapy. What I would like to do is to talk to you a little bit about radiotherapy, just conventional radiotherapy as many of you will have experienced, hoping that I'm not teaching my grandmother how to suck eggs and telling you things you already know, mainly to put into context why there is a role for proton beam therapy and actually what proton beam therapy is. So Paula has already alluded to this. Radiotherapy is the use of ionising radiation, and in the UK, ionising radiation in terms of radiotherapy is X-ray therapy in the treatment of cancer. And what does it do? Well, it delivers a dose to the DNA of cells, and cells are damaged by that and they aren't able to replicate. Radiotherapy, as many of you are aware, affects both normal cells and tumour cells. The thing about radiotherapy or radiation damage is normal cells have a capacity to repair themselves, which is not present in many tumour cells, and that is why radiotherapy works. So the next time the cell tries to replicate, it dies rather than replicating. How effective is radiotherapy? Well, actually, if we put cancer cells into a Petri dish and grow them in a lab and give them enough radiotherapy, we can theoretically cure any cancer with radiotherapy. But unfortunately, we all know that this is not actually the reality, and we aren't able to do this. So why aren't we able to do this? In part, we aren't able to do this because of inherent tumour radiosensitivity. So some tumours are far more radiosensitive, i.e., you need much less dose to kill off that tumour than other cancers. So for example, we talk about cancers like leukemias and lymphomas as being very radiosensitive, and brain tumours are at the other end of the spectrum, are not terribly radiosensitive. There's also the issue of normal tissue damage. While I said that normal tissues normal cells can on the whole repair themselves, they can repair themselves to a degree. If you give them enough radiation, they will no longer be able to repair themselves. And many of you who have had radiotherapy know that normal tissue damage results in the acute radiotherapy reactions that you may have suffered, and sometimes go on to lead to late radiotherapy damage, which happens months or years later, which you unfortunately then have to live with. Okay, so the idea of giving radiation is to try and limit the normal tissue damage while obviously getting rid of the tumour. And we can try and limit normal tissue damage by using as small fields as we possibly can, but bearing in mind that giving a very small field and missing the cancer is radiotherapy that wasn't worth giving in the first place. We can shape the fields to try and shield out normal tissue, and we give radiotherapy in what we call a fractionated way. So we give it a little bit every day. And the idea of doing that is that the normal cells have a little bit of time to recover, because we know that they can do, so that you can continue giving radiotherapy to a curative dose. So the whole of radiotherapy is this balance of trying to get the balance right between getting rid of the tumour and limiting radiotherapy to normal tissues. And I think in the last certainly 30 or 40 years, radiation has come on a long way, and certainly in my working lifetime, we've seen great advances in radiation. And I agree with Paula's comment that chemotherapy has always seemed to be the place to be, where all the trials are happening. But I actually think that in the next 10 years, the place to be is radiation oncology, and it's radiotherapy that has a lot of gains to make. So just talking a little bit about IMRT radiotherapy, which is intensity modulated radiotherapy. If we look at this, so this is a brain tumour, and the tumour is this little bit in red that you see here. And this brain tumour here is right next to the brainstem, and you need your brainstem to do functions such as breathing, so we don't want to give that bit too much radiotherapy. And you can see the optic nerves are running through here. And obviously we don't want to damage the optic nerves, because then you wouldn't be able to see, and that wouldn't be a very good thing. And if you're a child, well, even if you're an adult actually, your pituitary gland is sitting there as well. So there are all these sort of important normal structures, and here are your temporal lobes, and we use our temporal lobes to do a lot of our thinking, our mental processing, and to deal with memory. And this is the conventional way of giving radiation. And so we give it with two fields coming in from either side and a field coming in from there. And you can see that we get a nice dose to the tumour, so high doses in red and going down to blue, and the sort of treatment doses in the red-yellow part of the spectrum. And the blue dose is the dose we don't really need, but we get because of the physical properties of X-rays. So there we go. So that's fairly conventional radiotherapy. It's good, effective, but it comes at a cost, and the cost is that it's quite close to your brainstem, it's quite close to your optic nerves, and actually the tumour isn't square, is it? It's sort of blobby shaped, but it's got these bits here that you could carve out. So if we used IMRT, which is intensity modulated radiotherapy, which can be given with X-ray therapy, you can see that actually we can shape it much better. You can see that now the dose is looking a little bit more like this blob. It's not looking so rectangular. We can possibly carve out part of the optic nerve. We can possibly come a little bit closer to the edge of the brainstem, or exclude more of the brainstem. So intensity modulated radiotherapy, particularly for brain tumours in difficult to reach parts of the brain, may be the way forward. And that's deliverable now and is being delivered now. However, there is a limitation to IMRT, and what I showed you there was where all this dose had been pulled in and the temporal lobe wasn't getting so much dose, isn't the whole story, because actually it depends where I set my dose mark. So my dose mark here is 100% of the dose, but here is about 30 gray, which is about 2/3 of the dose. So I'm showing you 2/3 of the dose is going out here and 2/3 of the dose is around here. However, if I set my dose counter a little bit lower to show you, say, 10% of the dose, 20% of the dose, you can actually see that what was 30% of the dose here, when we look at the 10% part of the dose, it's smearing quite a way around. And this is the sort of burden of IMRT, that we end up smearing more radiation around. It's low dose, and it may not be important, if I'm honest. We don't know how important it is smearing that low dose around, particularly in adults, because your brain has finished growing, you're already processing information. In a child, however, where they are still putting down their electrical connections and they are still learning and they're still developing, actually probably smearing dose around is more significant. And actually perhaps it's better to have a lot of high dose going through here and no dose going through there. So perhaps the conformal plan for children might be better than the more shaped IMRT plan. So that is where proton radiotherapy, I think, is very exciting. What is a proton? Well, for those of you who can remember back to your physics, this is an atom, and a proton is a nuclear particle. So inside the nucleus, you have protons and neutrons, and these are what we're talking about. So why are protons exciting for radiotherapy? Well, the exciting thing about protons is, as they go in with their energy, they hit a tissue, they deposit their energy. They then deposit a peak of energy, i.e. a peak of dose, and then a few millimetres later, there is no dose. How does this compare to X-rays? Compares to X-rays like this. So this is a spread out proton dose, and this is, so if we assume the tumour's here, with X-ray radiotherapy, you can see that you have an entry dose and an exit dose. And this is dose usually to normal tissue that you don't actually need to treat. Now, I don't want to oversell protons, because I don't think protons are the answer to everything in any shape or form. So if we're fair, there's still an entry dose with protons, but there's no exit dose. And this lack of exit dose is very exciting. What does it mean? It means that we could shape the beam. It means that there are some tumours that we just cannot get the treatment dose into. The treatment dose is 70 plus gray. We know it's a huge dose. And I'm talking about these sort of tumours, which are in the base of your skull. You've got your brainstem running through here, your optic apparatus here. We know this sort of tumour needs 70 gray to treat it effectively. Your brainstem can only really tolerate about 50 gray of radiotherapy before you get quite catastrophic side effects. Your optic apparatus similarly. So even with IMRT, these tumours aren't particularly treatable. So what we can do is that we can dose escalate with protons, i.e. we can, because if you have a dose coming in here, but there's no exit dose, you can actually protect much of the brainstem. You can protect part of your optic nerve. you could potentially decrease late effects. So, for example, in a lot of what I do in paediatric radiotherapy, I don't need to dose escalate. I can get the dose in with conventional X-ray. But what I might be able to do is not treat so much growing tissue and therefore decrease the late side effects for children. So this is, again, looking at this dose bath picture. So the red is our treatment dose, the blue is dose that we don't need. With X-rays, if I was treating an eye, this eye, I mean, we wouldn't actually treat an eye with a single beam, but this is just a pictorial representation. You can see that 10% of the dose is exiting through the contralateral or the other side, the temporal lobe here, and that's not good for a child. Whereas with protons, this is still the 10% dose, and it's actually stopping right here. So you can see very easily there is some gain to be had. This is a picture of what we call craniospinal radiotherapy, and unfortunately many children who have a particular type of brain tumour, medulloblastoma, require radiotherapy to their whole head and their entire spine because we know the tumour's propensity to spread down there. And the way that we give it currently is we give radiotherapy to whole head, whole spine, but with photons, i.e. X-ray, conventional radiotherapy, there's a significant exit dose through the front of the body because we can't stop that. That's just the nature of X-rays. With protons, the there's no exit dose. The 50%, which is coming out here somewhere on this picture, is somewhere around here. Now I can show you picture after picture after picture, and you can think, oh, it's all very well showing us pretty pictures, but actually, is it deliverable? Well, actually, there's been a very good paper showing it is very deliverable. So here is this is an MRI scan, so a scan of, this is probably in adult or teenagers, because we'd never stop a radiation dose halfway through a child's spine, because obviously as they grow, the bit that's radiated won't grow, and the bit that would does grow, and so they'd end up curved. So this is clearly an older patient. So there's an MRI before treatment. This is a picture of the radiotherapy as it was supposed to be given. So there's the dose line, sort of 10% dose line, running halfway through those vertebral bodies, and this is what they intended to deliver. And the post-treatment scan shows they did in fact deliver it, because this line here is the marrow change associated with radiation, and in front of it you can see that that marrow hasn't changed at all. So actually the protons stop where we think they're going to stop. It is deliverable. So that is the reason why we think proton radiotherapy in certain groups of patients, not for everybody, but in certain groups of patients, may be very exciting and a worthwhile endeavour. What is the literature, what is the research out there? Well, there isn't a huge body of research, in part because these tumours are very, very rare. So Paula was talking about recruiting 400 or 500 patients over a 3 or 4 year period. For medulloblastomas, for example, we see 80 in the UK in a year. So you can see that actually getting big numbers to do these trials that would be significant, statistically significant, would be actually quite difficult. We can collaborate internationally, which we do, and we try very hard to recruit into those sort of trials, but again, they're still very small numbers, and we also have to overcome national prejudice. So if you think about just in politics, the way that the EU doesn't necessarily all work together, it's the same in medicine. We have different ways of approaching things, different treatment strategies, and trying to get everybody to treat in the same way on a trial can be very difficult. We do it, but it can be very difficult. This is just more pretty pictures showing you that actually with protons we can shape the beam much more. So if this is so wonderful, why don't we have it? Well, one of the reasons we don't have it is it's not just like getting a LINAC and putting it in a room and starting it off, which is something that we're very good at doing and something that's deliverable. What you need to produce protons is you need a particle accelerator to produce the protons, and actually what then happens is that rather than having a one particle accelerator per room, you have one particle accelerator that supplies 3 or 4 treatment rooms, and the beam switches from room to room. And the reason for that is this is a particle accelerator, and this is this is the floor, and if a person was standing, they'd be about this high. So the particle accelerator is really quite big. It would be a sort of a third of this room and almost the height of this room. Then, in order to remember the diagram showed that the beam goes down a line. So this is the beam line, and there's magnets accelerating the beam and also moving the beam into each room. And these are the gantries, because obviously we want to be able to treat a tumour from all angles, and just having a beam coming out of the wall at one side is no good, because actually it would be all right if you're always treating from this side or that side, but you can't really tip patients upside down and hang them up by their ankles. And so you need to be able to get a beam to go 360 degrees around a patient, a bit like the Lennox do. And so we have to have these huge, huge gantries. And these gantries are about 3 stories high. So and each treatment room would have a gantry, so these are really rather large pieces of apparatus. But actually from a patient point of view, because if you were put into the middle of a machine that was 3 stories high, you might have second thoughts about whether you wanted the treatment. Actually, where the patient lies, there's a bed here, what you see is actually very small. This is all behind a wall. Okay? So it isn't a question of just buying a machine, installing it in a building. You probably have to build a new building to have it. There are centres that have been treating around the world, and certainly in America, they have had a long history of treating with protons. Many proton facilities started off in the physics laboratories, so they weren't particularly clinical. So the linear accelerator was producing protons for other things, and someone said, oh, you could actually treat patients with it. So they hived off part of the beam to a room in a physics or a university facility, so they weren't particularly clinical. It wasn't till the 1990s in America that actually they started having clinical facilities, and clinical facilities have been growing more and more and treating more and more patients, and there is now some literature coming out about how the long-term effects of proton beam radiotherapy, which we hope show some, particularly in children, hope show some benefit over photon radiotherapy, particularly in terms of late effects. So where are we here in the UK? Well, we have no high-energy proton facility in the UK. There is a low-facility proton machine in Clatterbridge in Liverpool, which treats eye tumours and has a long history of doing so, and is internationally recognised for this. Since April 2008, there's been a service that's been nationally commissioned in the UK to send eligible patients abroad for treatment, and this is the website where all the information can be found. And what happens there is, if you are suitable for proton radiotherapy, and I'm going to show you in a little minute those people who might be suitable for proton radiotherapy, you're referred to a national proton panel. And that's made up of clinical oncologists with a special interest in protons, and there's an adult panel and a paediatric panel. And for example, I sit on the paediatric panel. Clinical oncologists send us information on appropriate patients. We look at the information, and if proton therapy is thought to be of benefit, they get sent abroad for this. When this service started in April 2008, in the first year, 20 patients were sent. In the last financial year, over 100 patients were sent. And when I say were sent, they're sent to either Switzerland, but more likely to America, to either a centre out in Jacksonville at the University of Florida, or to Oklahoma City. We are very excited, particularly at UCLH, because the Department of Health has recently, in April this year, announced that there will be 2 proton centres in the UK, and they will be at the Christie in Manchester and at UCLH in London. However, it's going to take us quite a long time to procure the equipment and actually build the facility and commission it, so we're not expecting to be clinical until 2017. So currently, these are the indications. So if you have this as your diagnosis, these as your diagnosis, you may be considered for proton radiotherapy. The adult list is quite short, and that reflects these sort of tumours that, as I showed you in that first picture, that are the base of skull tumours or spinal tumours that need very high doses of radiation, and we're not actually able to deliver these with conventional radiotherapy. So even IMRT struggles to deliver the doses required for this. The paediatric list is much longer, but looks very long, but bearing in mind many of these diagnoses, there will be less than 80 in the whole country in a year, if even 80. So though this looks like a long list, the number of children being sent abroad is still quite small, and for many of these, this is all about trying to decrease late side effects, and many of these are to do with many of these are brain tumours, so we're hoping to decrease the integral dose, or the dose spread around the child's brain, to try and preserve their IQ. Children are still growing, and your pituitary gland, which sits between your eyes, helps you go through puberty. So if you are prepubertal and we irradiate that, that means that you need growth hormone injections to go through puberty. children's bones are still and muscles are still growing, so if we can limit that, that means they might grow more normally with less deformity. So for example, if I could exclude treating your face, your facial bones for example, your face would grow up normally if you had a tumour sitting behind it. I think the important thing to say is protons are not a magic bullet, however. The radiation still has to get in, so as I showed you at the start, there's still an entry dose. And equally, the high dose area, so where I need to treat, and as Paula was explaining, if you were treating a lung cancer, you end up having to treat some of your gullet as well, and you get that pain on swallowing. That doesn't change with protons because your gullet is still part of the high dose area, for example, in that case, because we still need to treat the tumour and the tumour abuts that. So I don't think one should go away thinking that protons are a treatment that has no side effects, because that certainly isn't true. What protons are trying to do is to, in those cases where we can't give radiation, increase cure. In those cases where we do give radiation, try and decrease the late effects of that radiation. And for some children, those late effects can be absolutely devastating, and that is what we are trying to lessen. So again, obviously to be sent abroad for proton radiotherapy, we have to be treating you with curative intent. It's a long way to go. Radiotherapy is given in a fractionated way. Proton radiotherapy is no different to X-ray radiotherapy. Most of these courses last 6 weeks of treatment. You need to go out beforehand, have your radiotherapy planning, as many of you would have had, but many of you who would have had radiotherapy planning would have then gone home and carried on with normal life until your radiotherapy started. If you're going abroad, if we send you to the States, we're not going to bring you back for 2 weeks, not only because of the cost, but what happens if in America, when they're doing the planning, they suddenly realise, actually, we need to check something, then you have to fly all the way back. So once you're there, you're there. So essentially, you're there for 3 months. So it's quite a big undertaking. You have to be good performance status, but that's probably true of most curative radiotherapy. You need to be of good performance status. We don't have, you need to be otherwise well. So we don't want to treat somebody who has a curable cancer, but who perhaps might have some other limit to their survival. And again, that just goes with the idea that one of the big gains of proton radiotherapy is the decrease of late effects. No metastatic disease, which sort of fits in with that, and no retreatment cases. And that's mainly because a lot of the proton centres we're sending to don't want to take retreatment cases at the moment. So the pathway looks very complicated, but in essence there are 2 steps to it. One step is that you're on the indications list, that you're prepared to go, so your clinical oncologist makes the referral for you, the proton panel looks at that referral, and when they look at it, they will look at the clinical information or the imaging or the pathology, a little bit like being discussed in a multidisciplinary meeting. If it's decided that you would benefit from protons, the panel says NHS funding has been agreed. We then have to get you accepted by one of the 3 proton centres we're sending to, so it's a 2-stage thing, because of course we can't force a proton centre to treat something they wouldn't otherwise treat, and then you're ready to go. What the National Commissioning provides is it provides obviously the cost of the treatment, the cost of any medical treatment associated with your proton therapy. So if you get side effects, need to be hospitalised. Many of the children receive concurrent chemotherapy. So if that's needed, that is all covered. It will also pay for, if you're an adult, it will pay for one other person to go out with you, because it can be very daunting to go out there. You might not be feeling your best, so it's good to have a carer with you, so they'll pay for a carer to go out with you. If you're a child, they will pay for 2 parents or two carers to go with you. They will sort out your accommodation for you, and those accommodation costs are met. What is not met is subsistence, so eating, so food bills are not met, but even some transport costs. So many of the centres in the States you need to be able to drive to, because in the United States there is no real public transport. I managed to get from North London into Central London, up to Sheffield and across to Meadowhall without any problems by public transport today, and it actually door to door probably took me just under 3 hours, which is really quite impressive. In the States, a similar journey probably take you days. So what again the National Commissioning Group will pay for is for car hire if you're willing to drive. So if you are eligible for proton radiotherapy, the ethos is to try and make it as easy as possible for those patients and for their families to go there, but it is a big undertaking, and because it is such a big undertaking, we know that there are patients who might benefit who can't go out because they can't take all of this on, and therefore it would be good to have some UK centres, and hence the centres at in London and in Manchester. I think it's very important that those centres collect very robust outcome data, because we have to prove that this investment in this sort of radiotherapy is worthwhile. So I think, as I progress through my consultant career, the challenge for me will be to choose the right technology of radiotherapy for the patient that's sitting in front of me. Just because something is new and shiny in a new centre doesn't necessarily make it better. We have to be very thoughtful about how we choose which radiotherapy modalities are the best for our patients. And obviously, as patients, you have a very big say in the side effect profile, both acute and late, and we need to be able to talk through not only what the chance of controlling or curing your tumours are, but also at what cost does that cure or control come. Thank you very much for your attention.